So I'll try to address the concern about labeling and how to express concerns for age of the child. Um, well, part of the discussion was at the workshop was trying to look at the different time periods in which we can gather information, neonatal period, and the earlier, neonatal period with colostrum versus mature milk, and recognizing that as we move forward in guidance and discussing how to approach these studies, that'll be important to try to capture information in each of these spaces. There were some interesting and actually exciting ways in which folks were working towards this goal. And I think in that sense, we can reflect in the labeling where information is known, particularly related to the time of, and period of exposure. Melissa, did you?
So I think your suggestion in terms of being accurate to what we know, particularly for the risk to the infant and then the child, is something that we're going to have to work into our descriptions of the labeling. The advantages of this new labeling rule is that we actually have the space and the ability now to be very clear about the assessment for risk. And it is, as you're hearing, primarily a risk to the infant. We have some opportunities to talk about the risk to the woman who is breastfeeding. But then again, the entire labeling should give us information because this woman is a woman who's going to have, respond to the drug, as she would whether she's breastfeeding or not. Some of the challenges we have here is something that Tamara alluded to, is we can only put in what we have. And what we have not is far greater than what we do. And so this is part of our discussions, particularly with external interested parties and stakeholders, is help us figure out how to get this data to come in. For your particular suggestion, we need to move to the neonatal community very quickly and fill in the gaps as soon as we can about data for just normal developmental sequences, particularly of receptors in hormones and all of the things that you're talking to. We know some of those things, and I do agree with you. I think we can figure out ways to get them in. But in the absence of that information, you're not going to see that right away.
Well, and thank you for that. I would just comment about the domperidone. The alternative is herbal, using fenugreek, which is a combination of 18 or 20 active chemicals. It's a plant. And currently, I don't think the FDA comments on herbals. And so what's happening is that, unfortunately, people are using fenugreek, which is far, far more risky than a drug about which a lot is known in other countries.
You bring up a good and complicated point. FDA's oversight of a variety of products are defined by the law. So there's certainly if a substance is a drug, we would have oversight over that. And even within that space, there are limitations. Things that are dietary supplements and what have you, I mean, as you are aware, or oversight of that is very limited, if any at all. So that might explain some discrepancies that's out there regarding our messaging.
So what is our recourse for drugs that we do have problems with? I have a Depo-Provera embarrasses milk supply. our OB colleagues say all the time, there's no problem. And yet we continuously see mothers who go on Depo, have a drop in their milk supply, and of course they're going to start supplementing, and there's the end of that. And they're not informed that that is a possibility. And I don't see it in your labeling. So what are we supposed to, what's the recourse to get that out there?
Well, I haven't looked at the Depo labeling lately, and to be honest with you, I don't know if it's going to undergo PLLR by 2020. Again, there are very specific rules which labeling will undergo PLLR. For an old drug like Depo, I'm just not really 100% sure that's going to happen by 2020. That said, what we put in labeling will have to be supported by data. If there are good studies out there showing an adverse effect on breast milk production, certainly that would be reviewed by FDA, and if warranted, will be reflected in labeling. So that's why we're here in part to let you know where the huge data gaps are, and if you can spread the message in terms of getting the data analyzed, getting the studies done, getting the data analyzed, getting it published, call our attention when there's a good publication out there. We certainly would be more than willing to review the data to update our labeling.
We have a process that you may or may not know about in terms of having us receive, say, a new publication or some concern that you have about safety. And that will trigger a review internally for us to determine whether there's a level of action that we need to be taken. And I think you may be aware of a communication that we have called a drug safety communication. And this is an public announcement that the FDA has received some information that they are concerned about and are launching a thorough review. And at the end of that review, if we determine that that safety signal is in fact real and is in fact one that is not already noted in labeling, that is enough for us to go and ask for that labeling to be changed. But we can't do that unless we're more formally made aware and there's a decision that there's sufficient information for us to launch a thorough review. That's our process.
Also, I like to just call out, I know it seems like an unlikely partnership, but certainly a lot of the submissions that come to FDA for review come from the drug companies that own these drugs, because certainly they have the legal responsibility to keep their labeling accurate and updated and not misleading. And it is something that obviously if they violate, they will be penalized. So I would tell you from personal experience, we've had outside groups who would work with the drug company to call their attention to X, Y, and Z and have the company submit the submissions to us, which is the typical mechanism of action for these labeling changes.
Arthur Edelman, from Editor-in-Chief of Breastfeeding Medicine. I think I join with Ruth the compliment of the action of the FDA in terms of revising what the material and the content of the labeling is. If I could be a spoil sport, however, there is two concerns, I think, for those of us who are on the front line and have to make the decisions. One is how really updated it is. And once we have labeling, is there a process for reviewing this and updating it, something that may have been accurate up to the point when it was published? I have no sense of how often this is being reviewed and the request for updating and changing the labeling. Maybe more importantly, there's a sense and flavor, and yesterday I talked about phraseology and what the underlying message is. There is too much hedging at the end, or as I say much more grossly, covering one's derriere, leaving it to the clinician, giving this wealth of information. The average clinician cannot really interpret in an accurate way and make the decision. And the hedging and the phraseology at the end really means, when in doubt, stop the breastfeeding. rather than saying, when in doubt, the default is continue the breastfeeding with the drug. That's the flavor that comes across. I just want to express that, and I think I'm expressing more than my own personal opinion. I would also like to know what the relationship is to LACMED, which is really the source for most people nowadays to find out up to date. And the sense from LACMED that gives much more direction to the clinician. No, labeling, as good as it is and better it is pretty much ignored, to be honest. We go right to LACMED and get pretty much a flavor of what to do. And LACMED, the sense is that's being updated on a regular basis. So I would like to hear a little bit comment about where LACMED sits, and that's a federally also funded program as opposed to what the FDA is putting out through its labeling.
Well, I'll address half of your comments, which has to do with how updated is labeling, and I sympathize with your position. The labeling is like a textbook, right? It's not something that gets updated on a regular basis, like LACMED. So that is the reality. Secondly, what we include in labeling, we take very seriously. When we update a labeling, sometimes it takes us months and months of review from a variety of disciplines, and everyone weighs in on the validity of the data we have in front of us. I mean, even some of the big studies that's out there that, acquires a lot of press coverage, we review those studies and we know there are so many deficiencies in there that you just can't put it in print in a label, because when we put something in labeling, it does have our so-called blessing. And so the speed updating is certainly appears slow, I think, to the public for those reasons. Secondly, the default message about, when in doubt, stop breastfeeding. I can speak for all of us, the three of us sitting up here, that we are very committed in trying to change that paradigm. We're, with the PLOR, I feel like we are moving into an era. We're beginning of that new era. And we're hoping to use that space in labeling to modify that message. When we don't have data, we just don't have data. We can't tell you to stop breastfeeding. We can't tell you to continue breastfeeding. All we can say is that there are no data. There are no benefits of breastfeeding. So look at your patient, look at her risk tolerance, look at her need for medication, and that's where the clinical decision making is made. It's not made in labeling. It really can't be. There are too many different patients with different needs and situations. So that's sort of my extended comment on that. Do you want to handle LACMED?
Okay, so what is the relationship with LACMED, you ask? Well, when the reviewers are looking at information, not only are we looking at information that has been sent, as we are requiring now with all of the applicants coming for conversion to apply PLLR, we ask for them to provide a review of the literature, provide a review of what information they have particular to their drug, so that we can make sure that the information coming into this label now is updated, regardless of when they last updated. But we're looking at LACMED, we're looking at a number of other sources that reflect expert opinion in the lactation community, and pulling together a recommendation that the goal is to be consistent with what is known. So we are aware of LACMED. We refer to them as well. We've recently had some interaction with the outreach group there, and it appears that it may be a good mechanism, for which, what is the word, for that consistent, trusted source. Again, so it was clear, we just need to make sure that the messaging is consistent across all of these groups, and we hope to reflect that in the labeling.
I must admit, the way you phrase that, I found it extremely confusing. And again, I see it from the perspective of somebody who has to make the decisions with the patient in front of me and the mother in front of me. LACMED presents itself as a federally sponsored thing. It has all its right labels. And one would almost come to the conclusion this is really what at least the federal government, the U.S. government, wants to convey in terms of safety. And you say, well, I'm writing for FDA and getting labeling. I use LactMed as one of the sources. There are other sources. At least they should be part of the same process. They should be equal to you. Maybe something's very confusing here.
So
It's not another. It's not Tom Hale. It's not another. Publication talking about. There are thousands of them out there. Reviews it, and they come with a label. They come with an imprintur. Now, maybe you say we shouldn't be interpreting LactMed that way, but in reality, that's the way it is. So what is this that you only look at them and you get some advice, it's input, but there are inputs for everything else? One would think LactMed would be equal part of the process of the FDA.
Oh, don't get us wrong. We love LactMed. We're very very excited to partner with them as much as we can. Excuse me, but we have slightly different mandates, and by that I mean we are bound by some different rules within this nature of writing labels, and one very specifically is that we must and struggle to the best of our ability to provide the clear information that is available. But we cannot, and we are not allowed, to cross a line into what might be considered the practice of medicine. And we have this conversation endlessly. This is not a line that other parts of the government necessarily have. And in this particular circumstance, it's a good thing. So we're bound again. So you're going to come back. We're going to come back and we're going to say we need the data. We need to analyze the data, and we need to write in the labeling what we can based on the information that we have. And we're bound up a little bit by that. I do want to get back to this point of tipping the balance to the understanding of the benefits of breastfeeding. The first step is what you're seeing here is an expectation now in this new rule that there will be a statement when we have comfort to know that we should be reminding people that this is a benefit-risk decision for the patient who's in front of you, and that there is a true benefit to breastfeeding, which is why we're very excited to maintain our engagement with you all and others to get that message out there. So it's a lot easier when we write these labels. It's very hard when we live day to day in safety risk, and we had to pull ourselves back up and go, wait a minute. It's one thing to know what the risk is, but our job is benefit risk. And that's what this new rule is going to allow us to do in a much more clear fashion. But it's hard. It's very hard.
I actually just like to add one point that's important. Again, just going back to Melissa's point about FDA not dictating the practice of medicine. That is something we respect actually tremendously when we write a labeling. But along your comments, LactMed being a federal agency, we pretty much should be on the same page. Isn't it just we give them a call, look at the website, and just apply what they have? A very important distinction with FDA is that we have access to a lot of proprietary data that's not available to anyone else, and we're not allowed to share that with anyone else. We're not allowed to. So we do review all the available data, literally. It could be from Europe, it could be a drug company, it could be LactMed, it can be a variety of sources. So I think that's what Tamaro's trying to point out. We do ask drug company for all of their available data because these drugs are marketed in many countries. So again, those data are not available for public viewing that FDA gets to see.
One more question. And then we're going to have to move on.
Sorry.
I'm Ann Kellums from University of Virginia. Easy question. I've never applied for FDA drug approval, so I'm just wondering how much of what the companies give to you ends up sort of directly in the labeling versus your staff independently reviewing and writing the language themselves, because I just don't know how that process works.
So drug development takes a long, long time. You've heard 10 to 15 years. And that's probably still what it is today. As far as data and application submission, as you know, there's this whole prolonged drug development phase where we continually evaluate data through phase 1, phase 2, we evaluate all the, international data. When it comes to applying for a new drug application, FDA gets full study reports, we get all the raw data, we have the sponsors propose labeling. So that's our starting point. How much of it will look like the original one? Usually there are substantial changes. We usually make extensive revision after reviewing the data. Our goal is to approve a labeling that is clear, that is accurate, that is not misleading in efficacy or safety, and that's supported by FDA's independent analyses of the data. Now, during our review process, we do also look what else is out there. We don't just, look only at what the company submits, particularly for drugs that's approved elsewhere in the world. We can get data easily. Now, if it's a first drug approved anywhere in the world, then what we have is what we have. So it's a very extensive review process. And the final labeling that's approved goes through many different levels of review within the agency.
All right, I'll let you ask.
Really quickly.
Begging from the back of the room.
So Fatima Cody Stanford, I'm just want to specifically comment on the FDA's recent approval. I would say 2012 post of several medications that are used for long-term pharmacotherapy use for the treatment of obesity, which I appreciate. My question or concern is related to the fact that when these moms get pregnant, I do have to stop basically almost all of these meds because they have teratogenic potential, and what we're doing to look at when can I reinitiate the use of these medications, because what I see is as soon as these come off these medications, within a very short time they regain all of the weight that was lost on these agents, and so I'm concerned about that and what potential that has in terms of treating obesity from a pharmacotherapy perspective.
So I just want to clarify, meaning restarting after they've delivered the baby
Exactly.
and now they're lactating.
Exactly.
Got it. Okay.
Exactly. Maybe it wasn't as quick as I thought, but I mean, often we see patients, on average from pharmacotherapy, you're looking at 5 to 10% total body weight loss with these agents. But I mean, I have patients that have lost percentages that are well in excess of that. Right. And when I stop that medication prior to them, like once I find out they're pregnant, I'm like, oh my goodness, we've got to stop this medication. They regain that weight pretty quickly, and then in excess, and then we're basically back to where we started.
So none of us come from the division that reviewed and approved all of these.
Okay.
So we're walking carefully here.
Okay.
But my recollection is most of those products actually came forward in the old style labeling, so you're not going to see this, what we're talking about today. Mm-hmm. They are required because of the date of their approval to eventually be back in, so by 2020 you'll have this new format. Mm-hmm. My guess is that the labeling at this point says we have no information.
Okay. Yeah, that's
on
exactly
all of these.
Basically.
And so, at least for one that comes to mind in particular, we should have enough information from their component parts to put something together, I think, in the future.
You're
but
probably
again,
talking about Qsymia, phentermine, topiramate combo. Yeah.
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 And this goes to what Christine is saying. When that label comes in, we're going to do a lot of this work to capture what is available in the literature, or hopefully if somebody has actually done some studies and published them through, we will, we'll take a look at that.
Well,
But
tell
you're
the
right. I mean,
tell
right
the
now,
NIH to fund those studies, because I can tell you we're having a hard time getting approval for those
Yes.
studies. So
yes, I wish FDA were a funding agency, but we're not.
I know. That's what I'm saying. Talk to your colleagues. at
Yeah,
NIH.
well, we have some very good communication with the NIH branch. In fact, they were with us at the lactation workshop to hear where the data gaps were, and hopefully they'll take that back into their consideration. And the other again, and just to bring up something that Christine said earlier, one of the other places to turn your attention are, in fact, the companies.
Right.
And ask them for this information and ask it for them, and kind of drive some expectation that we get some of this for us to be able to communicate.
Thank you.